operating room, one of the most dangerous complications a surgical team can face is the aspiration of gastric contents. If a patient's stomach isn't empty when anesthesia takes effect, the result can be fatal. For decades, the primary defense against this threat has been the fasting clock. Patients are told not to eat or drink for 6 to 8 hours before a procedure, relying on time to clear the stomach. But looking at this vintage tincture of chloroform hints at why that rule is imperfect. These fasting guidelines are largely derived from clinical observations made during the 19th century era of chloroform anesthesia. Surgical practices have transformed in complexity and precision since this photo was taken at Borges Hospital, yet our baseline rules for fasting remain tied to the observations of that period. Relying on a historical average rather than physical evidence leaves a potential blind spot in modern patient care. A patient might fast for 12 hours, and their stomach could still be full. Biological stress and modern health factors can effectively stall the digestive process. When a patient is experiencing severe pain, managing diabetes, taking opioids, or using GLP-1 agonist medications, normal gastric emptying often slows or stops. Because these variables are so common, clinicians cannot always rely on the clock or the patient's recollection of their last meal. They need a way to verify the stomach's contents directly. This is the role of gastric point-of-care ultrasound, or Pocus. As you can see here, it is a non-invasive bedside tool that allows doctors to assess exactly what is currently in the stomach. It replaces the uncertainty of a patient's history with anatomical evidence. To gather that evidence, the clinician places the ultrasound probe just below the base of the sternum, at the xiphoid process. On the monitor, identify 3 landmarks to confirm the plane: the liver above, the spine below, and the pulsating aorta. Between the liver and pancreas lies our target, the gastric antrum. Zooming in reveals its distinct 5-layer wall, resembling a bullseye. By following this anatomical map, clinicians can bypass the visual noise of the abdomen to see the patient's digestive state. An empty stomach appears as a clear bullseye. Clear fluids fill the expanded antrum with dark liquid and bubbles, like a starry night. Swallowed food creates a frosted glass effect. Digestion then morphs this into a thick, gray smoothie. Identifying these textures allows the medical team to classify the gastric contents and adjust the anesthetic plan accordingly. Scanning a patient while they lie flat on their back can be misleading. Fluid may pool in deeper sections of the stomach, leaving the antrum looking empty. To verify the scan, the clinician rolls the patient onto their right side. Gravity pulls hidden fluids down into the antrum for a clearer assessment. This positional shift defines a simple grading system. If the stomach remains empty, both flat and on their side, that's a grade 0 stomach, indicating the lowest risk. If empty when flat but clear fluid appears when they roll over, that is a grade 1. This represents safe baseline secretions. However, if clear fluid is visible in both positions, the patient has a grade 2 stomach. This indicates a higher volume of liquid and a greater risk of aspiration. Using gravity as a check ensures hidden fluids don't complicate the surgery. If the ultrasound reveals solid or semi-solid material at any point, the assessment is complete. The stomach is considered full and the procedure is typically delayed. But if the scan shows clear fluids, clinicians can perform a final measurement to estimate the exact volume. While on their side, the sonographer freezes the image and digitally traces the outer muscular layer of the antrum. This determines the cross-sectional area. Generally, a measurement under 10 square centimeters indicates the volume is low enough to proceed safely. This measurement converts a visual observation into an objective data point. The traditional fasting clock is a historical observation of averages. It cannot account for the specific physiological delays of an individual patient. Ultrasound removes that blind spot. This display showing a clear bullseye pattern provides a direct view of the stomach's current state. In just a few minutes, these patterns give the surgical team actionable information. It serves as a primary safeguard against the risk of aspiration. By using real-time anatomical data, Gastric Pocus allows clinicians to confirm a patient's status, ensuring that when the anesthesia begins, the risk of aspiration is actively managed.